possible. This case shows a continuous curvilinear capsulorhexis with forceps in the presence of this very small pupil. Here you can see the sphincter, which demonstrates how wide the sphincter is. And as we were speaking a few minutes ago, how the partial sphincterotomy, the small snips, will only cut part way through the sphincter, still allowing sphincter function and with less distortion of the pupil. This tear is now being teased along somewhat larger than this pupil. By extrapolation, one can usually tell where the point of the tear is. The iris can also be retracted with the instrument to verify this if one is unsure. So this opening is made larger than this pupil. And here is demonstrated the use of another instrument to nudge the pupil aside, or one can stop and maneuver the edge of the pupil with the forceps to examine the point of tear of the capsule at any time during the capsulorhexis. The high viscosity viscoelastics do enlarge the pupil somewhat. And again, we're demonstrating the capsulorhexis with forceps, trying to puncture with the right hand jaw, then grasping the edge, extending out to under the edge of the pupil, making the capsulorhexis somewhat larger. Now, as demonstrated what was on the artist's drawing of nudging the pupil aside slightly to note the point of advancement of the tear. Different hooked instruments or Y probes can also be used for this. Fortunately, this picture is just a little grainy, so it's difficult to see. But as the flap of capsule is visualized, one can imagine the tear underneath the capsule. With the nucleofractus divide and conquer techniques, the removal of most lenses, unless they're very dense brunescent, can be accomplished through very small pupils and relatively small openings in the anterior capsule. The reason for that is that most of the action of the phaco tip is in the center of the lens. With the downslope sculpting techniques that we'll see later in this tape, you can see how the lens is maneuvered in the capsule to allow the phacomulsification to occur in the center of these small pupils. This case shows somewhat loose zonules. You can see the attempt at the puncture of the anterior capsule lens moved around a little bit. Small pupils are quite common in the pseudoexfoliation syndrome, So with the loose zonules, we have changed from the forceps to puncture the capsule to this cystotome, which is sharper and creates that puncture with less stress. So we're just continuing around now that we've started with the cystotome, showing that the capsulorhexis can be done just as effectively with the cystotome as with the forceps. If the opening in the anterior capsule obtained is too small, one can use the two-staged technique of capsulorhexis, either before or after the lens has been removed. Most often it would be used after the lens is removed. Interesting how when the lens is removed and the anterior capsule is flattened, the effective diameter of the pupil is larger, and one can then see more of the anterior capsule and can enlarge this opening with the two-stage capsulorhexis technique. You can see the pseudo-exfoliation debris on this capsule. Again, this tear does not have to extend the entire circumference of the circle, but just enough to enlarge it for lens implantation.